Welcome back to Mostly True Psychiatry with Dr. Mellon. Today we're talking about the atypical antipsychotic side effects as a group and kind of compared against the first generation antipsychotics. So the mostly true statements for first generation versus second generation is first generation has more EPS, more NMS. EPS basically both means acute and tardive dyskinesias. So tardive dyskinesia is those long-term permanent movement disorders when they happen or can be permanent. And then as well as akathisias and dystonias and stuff, the short-term things. And then, excuse me, NMS, which is neuroleptic malignant syndrome. So you're basically just thinking a person who's had a bunch of Haldol, they start to lock up, they stay locked up, their muscles break down, they have a fever, organ failure, death, scary. Second generation, its big things are the metabolic side effects, so more weight gain, more dyslipidemia, so like 10-year risk profile for cardiovascular disease, it goes up, and diabetes, which also increases death. The other side effects are pretty much specific to the drugs, so things like akathisia, probably the most famous for that in the second generation / third is aripiprazole. You give a person 15 milligrams on day one out of 3 patients almost starts to have akathisia. Seizure threshold gets reduced with some drugs, think like risperidone. Hyperprolactinemia, risperidone is the king of that one. QTc prolongation, ziprasidone. Simple, let's go for a slightly more complicated, I guess, explanation of these things since you are psychiatrists, very likely. Basically, the first generation antipsychotics they hit D2 and they just kept antagonizing D2 until they blocked 100% and people had Parkinsonism and stuff. The second generation, just consider third generation doing the same thing right now. It's not true, but and the newer atypical, call them that, antipsychotics, they have 5-HT2A, which actually increases dopamine. So you have D2 inhibition is reducing dopamine, 5-HT serotonin 2A is increasing it, and it makes it not go to 100%. Depends on where it happens for the side effect profile. So basic picture idea. 3 kind of major pathways, not drawn terribly well. I did this on PowerPoint. You have the nigrostriatal pathway going up there towards the corpus callosum with the blue. So that is the kind of the motor movement stuff. As you block too much of the nigrostriatal, you end up with Parkinsonism, akathisia, dystonias, locked up, that kind of thing. There's the tuberoinfundibular pathway. That's the little green thing going down to the little tiny pituitary gland there from the hypothalamus. And when that happens, basically you end up with hyperprolactinemia, and we're not going to really pay attention to the frontal cortex version. The kind of picture story you're supposed to think of for this, not quite correct, but good enough. So XXS just means more drug. You increase more drug, you have more of the Y-axis. Y-axis is D2 receptor blockade. It could be striatal D2 receptor blockade. It could be the mesolimbic. It could be the tubular and fundibular pathway. It doesn't matter. But the D2 receptors. Basically, you need 60% to have the antipsychotic effect. Obviously not always true because clozapine is the most effective and it's like 40 or 50%. General statement, block 60%. You start clamping down on the positive symptoms of schizophrenia. As you go to 80%, you get more. You can still have benefit and stuff. After 80%, you're probably just getting more side effects. Over 80%, depending on which pathway, you end up with more extrapyramidal side effects or hyperprolactinemia, and not a lot of benefit. So let's talk about the actual side effects for the atypicals. There they are. Let's do the black box warning first. Here it is. So the FDA version, increased risk of death and dementia-related psychosis. So when you're treating people with dementia who have psychosis with antipsychotics, it's been shown in short-term controlled trials, deaths in trials appeared to be increased deaths, what they're saying, appeared to be either cardiovascular like heart failure or pneumonia. So that was done because there was 2 observational studies, and then they reanalyzed 17 placebo-controlled trials, many unpublished, which awesome way to do science. You just don't even tell people what it is and just take my word for it. And they found increased deaths. It was 3.5% of deaths, number of deaths versus 2.3% on placebo, 1.7-fold increase. Obvious thing, are these the same patients? Are you treating people for psychosis because it's a real problem and it's a more severe, version, worse off version of dementia? Or are you comparing apples to oranges? Things we don't know. They've tried to follow up with different kinds of studies and different drugs, looking at them when they're for these patients. There's supposed to be a pretty significant difference. So if the number needed to harm to cause a death or something with Haldol was 26, it was 50 with quetiapine. So probably use quetiapine or olanzapine before you do Haldol or risperidone. Seems reasonable. Let's lump all of this as cardiometabolic effects. So the big metabolic highway you're supposed to know is you give a person an atypical antipsychotic, they get the 5-HT2C and histamine receptor blockade, it makes them fat, that probably some inflammatory thing going on, you get insulin resistance, triglycerides start to go up as you get fatter, and with the insulin resistance you get prediabetes and diabetes, and that's kind of the story that gets told. Let me do 2 things. So the drugs you're told are high risk versus low risk is basically clozapine, olanzapine, always horrible. Probably always start them on metformin if you're on those drugs, that kind of thing. Low risk is supposed to be aripiprazole, sinapine, lurasidone. That's debatable. I may get into it, may not during this lecture. The metabolic syndrome is what we're taught and we're supposed to know. So basically, metabolic syndrome is just a descriptive term of metabolic risk of these risk factors combined together. Diabetes type 2, atherosclerotic or dyslipidemia, because that leads to a cardiovascular disease risk, 10-year risk increase. Abdominal obesity, so-called central obesity, and high blood pressure and hyperglycemia. This is used by psychiatry, it's used by the Endocrine Society. I'm talking to general medicine practitioners, and they apparently don't really use this anymore. They don't have any benefit or see any benefit versus just treating the individual symptoms. Calling the symptoms something together doesn't help them. They already know to look for high blood pressure and dyslipidemia as a routine screening. So the big number you're supposed to be aware of is waist circumference varies men and women by 5 centimeters, 40 inches versus 35 inches. The triglycerides over 150 is considered bad. HDL less than 40 or 50 for women is considered bad. Blood pressure, if you have hypertension, is considered bad. If you have uncontrolled blood sugar, is bad, right? Like, okay, good, thanks. Let's see. All right, that's fine. There's a lot of controversy here. I'm not going to go into it for this lecture. All right, so let's talk about weight, because it's kind of related to that. It's hard to know what this means. I started looking at the actual meta-analysis and looking at individual studies, and I'm just going to say we don't know. It's a lot of garbage, and psychiatrists I interact with don't really look at it in depth, so they don't really know either. And definitely don't believe what the drug companies are telling you. Histamine blocking and serotonin 2C are going to cause you to gain weight. If you're young, if you're low weight, African descent, I guess, these are risk factors. I think that's questionable. That's too big of a population to merge together. Some people think the weight gain's is quicker early on. May or may not be true. The thing you're normally told you're supposed to believe is high risk, clozapine, olanzapine, definitely true. I don't think there's a lot of argument there. So, especially clozapine, it's a no-brainer. Aripiprazole is supposed to be low risk, lurasidone, ziprasidone. I argue with the aripiprazole. I think that's a new drug company nonsense. So All right, this is a table I built. I'm just going to say one or two things to give you or to show you why this is complicated and probably what you've been told is wrong. So, how studies are written, this is kind of how they do it. They give you the dosages of the drugs, so, Seroquel, 3, 6, 900 milligrams. The duration in months, it has to be long enough to be relevant. If you said, oh, look, no weight gain in 4 weeks, who cares? How big the sample is super matters. And then they all do the same thing. They use an average weight. They show you the standard deviation in the real studies. And then they give you the percent of patients who gain 7% of body weight. Now, the problems with this is, they will sometimes tell you the individual doses, like, 100 people were given 300 milligrams versus quetiapine versus, 50 people were given 1,000 milligrams. Those sometimes will give you that information. But then every time, I haven't found any examples contrary to this, they regroup all that information and you lose the dosage information when they show you the table. It always gets lost at that point. And so the only thing people focus on and what's always sold is the average weight gain or the patients who gain 7% body weight. And you have no idea what the dose is. And there should be a dose relationship. So it might say, like, you look here on aripiprazole, classic example. It's why I don't agree that it's a low risk for weight gain. So given 23 milligrams, which means it's a 30 milligrams is kind of an upper end dose. So they're given a normal dose, 20 or 30 milligrams. 4.5-month study, 350 people. It's a real study. The study stated average weight gain in kilograms, 0, or rounded to 0 because I round, 0. How many people gained at least 7% of their body weight? 1 in 5. That's a long ways from being low risk for weight gain. So don't get caught up in what don't believe what drug companies are saying. I mean, that's what to know about that. Hyperprolactinemia, basically this is legitimate. High risk risperidone, paliperidone, which is just the breakdown product. It's a major metabolite. Aripiprazole is definitely low risk because, fun fact, you can actually give aripiprazole 5 or 10 milligrams to a person who's, say, on 6 milligrams or 8 milligrams of risperidone. Only thing that works for them, you have to be on it, otherwise they're going to kill themselves and everybody else, right? You give them aripiprazole 5 or 10 milligrams, and it actually stops the hyperprolactinemia. So it legitimate is low risk. It actually reduces it. SIADH is always listed. I don't know what to make of this. I've never seen anybody with it. It's kind of case studies that have had it. EPS risk, extrapyramidal side effects. They're supposed to be high risk, Haldol, first generation, low risk, clozapine, olanzapine, quetiapine. It's supposed to be due to the serotonin 1 and 2A high affinity, supposed to help this. Tardive dyskinesia, I'm going to spend a few minutes on that real fast. So I'm just going to give you a few points to just know what you might be taught is still could be wrong. The DSM's wrong. So tardive dyskinesia, you can say it's 2 months, 3 months, 4 months, 6 months of permanent movements, right? Tends to be facial, shoulder, that kind of thing. That you have these permanent movement disorders or quote unquote permanent. Usually it takes that long to kick in. The children, typically the rule is that it always goes away. It's fine. It won't be permanent. The DSM just kind of puts it under medication-induced movement disorder, and it's got to be at least 2 months. That's before it's been there. It's been that long on the medication, or that long of the movement. Sorry. Now, the thing to know that is just I want to make sure we mention is that, so here's a big study I went through. It was like 57 head-to-head trials. First generation, there's over 30 studies, about 60 studies of second generation. It was a 2018 meta-analysis, etc. So first generation versus second generation, if you treat 20 people with second generation antipsychotic, you'll reduce 1 episode of tardive dyskinesia. If there's, quote, low risk for second generation olanzapine and the clozapine, you have to treat 100 to stop it. And the risk doesn't go up with the increasing dose of first generation. They can be on 50 milligrams or 5 milligrams, same risk on Haldol. And geriatrics is not a risk factor. That was taken away. It's not true. There's it's basically first versus second generation, and a little bit of variation in between. So, all right, hopefully that's been helpful.